Moving house or 11, moving house or 11.
Oh dang.
I've been studying for boards. I was on transport service.
Crazy, man. That's how it is.
It's like the worst week of my life.
Oh man, you'll be fine.
Oh yeah, and I'm working all weekend. I'm on call over
That's
ICU.
that you nephro guys, man, you get a rough schedule.
I didn't think it would be that bad.
Just use another account.
Oh yeah, that's fine. See, I can't. You see, I'm disoriented. I can't
No,
do
brother,
this.
don't worry.
Thanks, man.
I believe in you, man.
Alrighty. Don't judge too harshly.
We're all here to chillax, listen to each other. Don't worry.
Great. There's a few pearls. I think we all appreciate. Yeah.
Yeah, I mean, usually that's how it is. Just like just to give people like a taste of the topic. You want to download this and then we can open it up?
Yeah, we can download it.
Or whatever you prefer. This is
I
easy.
just printed. Well, this might crash, so I just do like.
So hit the download on the left. See it here?
Oh.
Yeah. And then open file. And then we should be rocking and rolling.
Yeah, close this out.
Yep. PowerPoint. Yeah, perfect. Maximize this. Hit the slideshow.
Oh, it's usually good. Oh, yeah.
All right, let me just share your screen, and then you should be good.
So I have to say that I have no Discord groups. I already signed the thing,
You already said that?
so it's technically I don't have to say it, right?
Yeah, I don't think so. All right, let me just say. Hey, can everybody hear us? I think so.
Start video.
We can hear you.
Okay, perfect. Okay, you don't need a start video. It's just it's gonna be audio and then your shared screen. Okay.
Okay.
All right, you're good to go.
Hey,
All
Sharon.
right, is it 12 o'clock? Okay.
We can wait. We can wait to
wait?
start. I don't care.
Maybe let's let them just
Okay, guys. Okay, full disclosure, I'm Jacob Noveck, PGY4 critical care nephro fellow. When I'm in critical care, I say critical care first. When I'm nephro, I say nephrology first. PGY4 here, and we're doing the conference, the Friday conference for specific syndrome, in this case, hyperthermia syndrome. And the way this is, I'm going to set this up is if you guys want to butt in, don't be bashful, and just we can bring enrichment to the conversation. And then for people on WebEx, if you guys say something, I'll just repeat into the microphone what you said so that people can follow along, whoever's watching. So don't be afraid to ask questions or say something or comment or just kind of like, insult. It's fine, anything. Okay, so the objective of to learn it, and I kind of try to compress it to make it a neat, clinically relevant lecture, is to first understand the basic pathophysiologic so you can identify what it is and why, and clinical differences between the multiple hyperthermia syndromes. In this case, it's 3. And it's difficult in the sense that they're differentiated based on clinical differences and not necessarily diagnostic criteria. But it's also very simple because they're very distinct different clinical features like the timing and those things, and we'll get into that. And then speaking of clinical features, then identify early signs and symptoms necessary for critical management of these patients. If these patients need to be seen initially without a full suspicion because they need to be treated as far early in the course as possible. So that's why this is really important. And then to differentiate the syndromes based on typo there, based on specific clinical criteria. So that's just what I said there. So you have the understanding and then what needs to be done, and then differentiated between the all 3. So, I mean, I'm not fancy. I don't have a beautiful case, but because we all know it, the serotonin syndrome, it's a board exam. You have a girl or somebody who is 22 years old, and either she came back from a party or she just started taking an SSRI, and she comes to the clinic or to the ER, tachycardic, diaphoretic, vomiting, nausea. She's obtunded, she has mental status changes, she has mydrias, her dilated pupils, and then her temperature is like 104. And then they ask you, what is this likely? And you're going to say, probably based on the clinical and findings, serotonin syndrome. And then the treatment is usually supportive care and benzodiazepine. So, but the thing is, serotonin syndrome is still a potentially life-threatening condition. It's one of it can cause hyperthermia because we're talking about hyperthermia syndromes, but it causes the least amount of hyperthermia of all 3. But it's associated with increased serotonergic activity in the central nervous system. And one of the first things to say about highlighted here, what you should differentiate between the three syndromes, it has a broad clinical spectrum with signs and symptoms and clinical diagnosis. Because if you think about it, serotonin affects everything in the central nervous system and the periphery, and it affects all these receptors differently as well. So you're going to get a lot of different things. One thing to differentiate it is that it has nausea, vomiting, diarrhea, those GI symptoms that neither does malignant hyperthermia or neuroleptic malignant syndromes have, because it's such a broad thing. So look for vomiting and those things like cholinergic, peripheral cholinergic activity syndromes. So, but then if it's severe enough and it lasts long enough, it prolongs into the course where you end up getting rigidity and hyperthermia. And but when that's the case, it's usually less severe and there's a much lower mortality associated with it. And it tends, like all the hyperthermia syndromes, except for, though they all can evolve quickly. The one that doesn't, that might not, is neuroleptic malignant syndrome, does not evolve quickly. It could take weeks or even months. But this one evolves quickly because it's related. It's usually related on it's a dose-dependent medication effect, and so once it's cleared, it won't be so effective anymore. So here's the little neuron. You have the serotonin receptors and this SSRIs. The way they work on the neuron is they inhibit the reuptake of the neurotransmitter, and then it breaks itself down. You have SSRIs and SNRIs. They prevent the breakdown of the transmission, so you have increased levels of serotonin in the synaptic cleft. Okay, it's for step 1 study. All right. So the symptoms associated with it, this is from an article that I've sourced called the serotonin syndrome. It's usually a lot of them, this has an increase in, this has like a prodromal effect, like a temporal effect similar to neuroleptic malignant syndrome, which I will address. But this one usually has somebody that comes out confused, anxious, as maybe you think they're delirium. Maybe you're in the ER and you think they're just being a pain because they're acting so crazy. And then they start to get sweaty, and then they start to get tachycardic. And then so it looks more, but the end you still might think that they're just behaving awkward and they're just excited. And then you end up with, and then later in the course, maybe a couple hours or so, you end up with the hyperthermia, then the tremors. Hyperreflexia is a big important finding. And then also is myoclonus, which is associated with the hyperreflexia. So if they have, so if you do a patellar reflex, you'll notice like if they're shooting their leg right, above their heads, or if they just start having tremors with the clonus when you're using your probe, then that's a very, as far as clinical findings, because there's no diagnostic. Well, there is a diagnostic criteria, but as far as clinical findings, that is one of the most specific ones, is the myoclonus and the hyperreflexia. And then, of course, hyperthermia and seizures can both be fatal. The seizures can either be a result of the hyperthermia because of the metabolic injury to the body, or it could be a direct result of the neurotransmitter toxicity in the brain. So, but seizures are a typical course that can develop, and it's not the same as the myoclonus because it's not provoked. It's just the patient will be seizing. Okay, so there is diagnostic criteria for serotonin syndrome, and it's also, but there's no lab tests or anything for any of these. It's based on clinical history and features. So you have to have the one thing, you have to know the patient took a serotonergic agent. It doesn't have to be an SSRI. It could be a tricyclic antidepressant. It could be really anything that acts centrally, gabapentin or something. If they take any kind of centrally acting medication that can indirectly or directly activate serotonin receptors, then you can consider that as a first criteria of your diagnosis. And then you only need one other feature, which is on this graph here. So do they have a feature? Have they taken an agent in the past 5 weeks? Or yeah, I guess it's pretty lenient as far as filling that criteria. And then you say, no, then you can't be serotonin syndrome. You can't have serotonin syndrome without an exogenous source of serotonin. If they have had something ingested, then you only need one of these criteria. The hyperreflexia being very specific with the tremor that's easily diagnosed. The spontaneous clonus, if you don't even provoke it and their legs are shaking, it's not a seizure, it's a tremor, it's a clonus. That's also very specific. And then if they become hyperthermic, that's actually very specific, but you have to differentiate between the other ones, the other causes of hyperthermia, because that happens not in all cases of serotonin syndrome, but late in the course and with severe cases. So if they're hyperthermic and you suspect serotonin syndrome, they probably definitely have serotonin syndrome. Okay. And then inducible clonus, if they don't have spontaneous clonus, but you can induce it, then you need one other thing, and just one of those other clinical criteria, whether it's agitation, diaphoresis, or any of the other things listed here. Okay. And then you go to your little yes, and yes, serotonin syndrome. It's easy as that. It's called the Hunter. If you're looking for the source on it, it's called the Hunter criteria for diagnosing. It's a bunch of clinicians got together and found a way to simply diagnose it in the case of serotonin medication overdose. Interesting so far? Yeah. Yes, sir. Mhm. Yeah, thank you for that comment. You mind if I share it with the others? So the comment was that there are as far as the agents that can elicit serotonin syndrome, a lot of times unknown agents, you can put it in that criteria because a lot of things that are commonly given to patients like antibiotics like linezolid or Zoloft or what was the other? Or MAOIs. MAOIs have a very high, especially if they combine an MAOI with the SSRI, which you're not supposed to do, but certain drugs have that kind of toxicity and it's unknown about. And those are all. So it's a pretty broad diagnostic criteria, and it's designed that way for a lot of different drugs that can have that effect on the central nervous system. Okay. So what's that? Oh, that thing's obstructing? I didn't know. What? Oh, okay. Sorry, guys. I didn't mean to ignore you. I just wasn't aware of the chat box. Okay, let's look at the chat box. Oh, so I want to lecture start. Okay, they just want to know if it started. Thanks. So if somebody has a question, I know if you have a question, I can see it now. Okay. So management of serotonin syndrome, usually supportive, because you can let if they're not severe cases, they don't have rigidity or clonus or hyperthermia, then you can just let the drug clear on its own. And then but the patients, they might get hypotensive or because they're sweating, they could be dehydrated, you can give IV fluids. And then oxygenation because they might have not, proper control of their voluntary breathing mechanisms. So oxygenation, pretty standard critical care thing, but these patients should be in the ICU because you don't know how they're going to progress and you don't know how the length of the course of symptoms will be. Chemical restraints. I thought I had this bolded. I thought I bolded this. This is a really interesting topic. So chemical restraints are preferred over like sedatives are preferred over physical restraints. Can somebody tell me why that might be a preference? Rigidity? Okay. But why? Yeah, they have fractures. Fractures could precipitate something that also might be underlying if they're hyperthermic and have rigidity related to, kidneys. Rhabdo, right, yeah. So you want to prevent rhabdomyolysis and fractures. So these patients, you'd rather sedate them with like a benzodiazepine than restrain them. Or you can intubate them and paralyze them, and that will also solve that problem as well. A lot of times, pretty standardly, if the patient comes up from the ER with serotonin syndrome, you have a high probability of the criticologist intubating the patient and putting them on a paralytic, or the ER doc. And I didn't come up with that name, criticologist. I heard it from attending at Cleveland Clinic, and I thought that was always a cool word. Okay, so benzodiazepines for sedatives, and then avoiding anticholinergic, like antipsychotics and antihistamines. I don't know if I had that right, actually. But so ignore that part about avoiding anticholinergics, but you want to use for autonomic instability control, short-acting IV autonomic agents that you can put on fast and you can take off fast. Like what's a good beta blocker you can put on fast and take off fast? Esmolol, right? What's a good calcium channel blocker? There you go. So all those things you want to be able to titrate because they're going to have all these crazy interactions with the serotonin receptors peripherally and centrally, and it's really going to it causes autonomic instability. So you want to be able to change course fast. So the hyperthermia. So think about the cause. So if they have serotonin syndrome, think about you have hyperthermia. We're all ingrained hyperthermia. Oh, throw dantrolene. But would dantrolene help in the situation? Probably not, right? Because it's not like a targeted effect of the skeletal muscle. It's a generalized hyper neurotransmitter synaptic situation happening diffusely. And it's caused by things going on centrally and not directly at the skeletal muscle. So the actual I have a chemical restraint highlighted here. Okay. So when you consider the cause of the hyperthermia, propranolol, maybe dantrolene, those things might have modest effect. Dantrolene won't have any effect in this situation, but propranolol might. But then you want to use short-acting beta blockers. You don't want to use a long-acting beta blocker because then you'll have worsening autonomic instability. So if these things are happening and they're not getting better, if they're going in the right direction, you don't want to change anything. They're clearing the drug and all that stuff. But if these things aren't getting better, then the antidote is cyproheptadine. So you've already given them chemical restraint. They're already intubated. You've already paralyzed them. They are getting benzodiazepine, and you're cooling them. If they're hyperthermic, now they're getting really hyperthermic, and you don't have a way to cool them. You use cyproheptadine. It's a broad antagonist to histamine and serotonin 1A and 5-HT2A. So it's a broad anticholinergic. Okay. Now I remember, if you'll excuse me, as everybody listening, why I said to avoid anticholinergics traditionally during the acute phase of the serotonin syndrome. And nobody will be able to guess it because I thought it was really interesting and really obvious. But it prevents sweating. It prevents diaphoresis if you use like Benadryl and that stuff. And so it'll cause them to heat up. Isn't that interesting? Okay, so you want to use a broad spectrum anticholinergic, shut the entire system down instead of just like pinpoint stuffs, and that's what cyproheptadine will do for you. And I don't know if everybody has it. It's not that commonly used because with proper management, you could probably mitigate all these unstable things with the supportive care that we talked about previous slide. So why not use antipsychotics though? Because like you can use a broad spectrum anticholinergic. Antipsychotics have pretty good broad spectrum anticholinergic activity, like Haldol or olanzapine or Geodon. Those are the same thing, I don't remember. But Geodon and those things that way you like to use to restrain our patients. Well, yeah, it could be, it might help, but you don't know if they're prone to another issue, which is called neuroleptic malignant syndrome, which is caused by antipsychotics. And that also causes hyperthermia and those problems. So think about that. It's just my segue. So neuroleptic malignant, yes, sir.
So why not use cyproheptadine early on? Why do we have to, wait? You said later on if they're not responding. It's a good antidote.
I don't remember the answer to that question, but maybe it has. Maybe I'd have to, what do you call it? Conjecture. Maybe it has to do with the clinical scenario. You might not have so much suspicion at first, and you want to be able to rule out other things before you do a definitive treatment for something. That's probably one of them. Yes, sir. So, yeah,
It's done, you don't always know for sure it's past diagnosis. That's I don't know for sure.
Yeah, I think the initial case here was just like 5 patients or something when it came on with the recommendation for Cyproheptadine, and it has its own, as you were saying, anticholinergic effects. So you want to try to avoid it for its own side effect profile unless you're dealing with moderate to severe cases. And even there, the data is scant.
so the question was, why don't we use cyproheptadine right at the beginning? And there are several answers. One was that what I conjectured, and then the other one was that the data is limited in its use because there's less. The initial study was like 5 patients or something. And then also its efficacy is, it's not like 100% efficacy issue. It's something that adds on, it's like an adjunct to treatment. So it's not technically like an antidote, like a one-shot kill antidote, but it has some evidence that it will block all those broad spectrum, those broad broad procholinergic activity. Okay. So the next topic is neuroleptic malignant syndrome. And so we're going to differentiate now between the serotonin syndrome, which is caused by SSRIs, and neuroleptic malignant syndrome, which is caused by antipsychotics and antiemetics, but mainly antipsychotics. And it has a different mode of activity. And you'll be surprised to realize that it's so different from serotonin syndrome, and things to look out for and physiological things to understand. It's defined as a life-threatening neurologic emergency associated with the use of antipsychotic or neuroleptic, that's an old term for antipsychotics, agents, and characterized by a distinctive clinical syndrome of mental status changes, rigidity, fever, and dysautonomia. So those are the classical things. However, there's not a specific diagnostic criteria for it, but those are the classic clinical findings. And then here's a quote from one of the leading people, a psychiatrist who has spent many years studying this illness, describes it as an extreme end of a continuum of severity of extrapyramidal side effects associated with neuroleptic drugs. So it's a spectrum of extrapyramidal symptoms that eventually lead to the fatal ones, like hyperthermia and rigidity. So the causes, really unknown. I was surprised to find this, but it's investigated by a lot of psychiatrists. They do a lot of things on it, but the mechanism is really not known. But there are a lot of good theories on it, and some that make sense. And you'll see what makes sense. You give me your opinion, see what makes sense to you. The most broad spectrum and most popular theory is that it's an anti-dopamine. It blocks the receptor blockade, which blocks the hypothalamic axis, and that can cause hyperthermia. And then also using antipsychotics on patients, and that people with neuroleptic think the rigidity kind of simulates or mimics Parkinsonian type symptoms. So and it's part of the syndrome, the neuroleptic syndrome. So that plus the hyperthermia kind of thinks that you have a similar mechanism of action of what's happening at the central point, and that those are related. So it has something to do with the dopamine antagonist activity. And then there's another emerging theory that there's actually direct toxicity to the skeletal muscle. And that would make sense because dantrolene actually works for neuroleptic malignant syndrome and not for serotonin syndrome. So you think that there's something happening at the targeted spot of the skeletal muscle. So those are two competing theories, or merging. Usually, like if you guys have a relationship, you argue with your significant other all the time, and every time you argue, you realize that you're both partially right. Does that ever happen to you? But that's a simple. They're probably both partially right. They kind of have the same similar story. Okay, so the diagnostic, there's no diagnostic test for NMS. I want to say NMS now from now on for neuroleptic malignant syndrome because I have an Invisalign in and I have a tongue tie. So there's no verified diagnostic test, and it's based on clinical features. So the first one is just like with serotonin syndrome. Do they take a medication? Do they take an antipsychotic? Do they take anything that acts centrally? Just think about that. It could be Zofran, by the way. It could be any antiemetic. It could be prochlorperazine or Reglan or any of those things. Metoclopramide, is the famous anti-dopamine thing that causes Parkinson features, right? So think about that. So promethazine, metoclopramide, any first or second generation, so Haldol or aripiprazole or one of the second generations. Every antipsychotic is implicated. You can't switch to antipsychotics and think it's more safe for neuroleptic syndrome. They're all implicated. And then the classical features, and then the second part of the diagnosis, like I said, there's no diagnosis test. So you just base it on your own clinical judgment, and then you can make the diagnosis. But they use an antipsychotic instead of SSRI, for example, because the SSRI won't cause it. It has to be an antipsychotic. It has to be a anti-dopamine acting drug. And it's very consistent, actually, the way it's clinically diagnosed. There's been studies about how it's noticed and how often it's caught. Is that the first thing that shows up are mental status changes, but not similar to the bizarre behavior of serotonin syndrome, more like a catatonic state, or psychotic state. Like they'll just be sitting staring at a wall and acting really strange. That comes in conjunction with the rigidity, the Parkinsonian rigidity. So if for some reason, he's on an antipsychotic, he takes it home, or he has gastroparesis because he takes Reglan, and his wife one day finds him sitting in a chair and staring at the wall, and then he can't get out of his chair, and then he's got the cogwheel or the pill rolling or whatever. That's the first thing that you see 82.3% of the time. And then, so those are coupled together. And then it would be followed by the dysautonomia. So your hemodynamic instability, and then the hyperthermia. The hyperthermia can be lethal. It's more lethal than serotonin syndrome. And the reason being is that it's not a dose-dependent thing. It doesn't matter how much, or how little, it just activates. And the other scary thing is somebody could be taking an antipsychotic for months and not have any problems, or years, and it could just bear itself. It just activates, and they don't know why. Some things that can help you, usually happening late in the course when they're already hyperthermic or having rigidity, is these lab findings. Get a CPK if it's greater than 1,000. If it's moderate or whatever, not very good. As we always get a CK, and in the ICU, it's always going to be 325 to 500. But it's over 1,000, that's pretty specific. And the higher it goes, the more specific it is. So if you have a patient with rhabdo and you're wondering, well, why is this 10,000 and why is it not going down? Think about the antipsychotic that you have, or the metoclopramide, or the antiemetic, whatever you're using. Think about that as a possibility. It doesn't hurt to stop it. And the interesting thing, it's also a risk factor. So a patient with chronic rhabdomyolysis, every time he goes to the hospital, they do a CK and it's 600, 300, whatever. These patients that have neuroleptic malignant syndrome that take these drugs for a long time, typically what they're finding is that they actually have a low-grade rhabdomyolysis always that doesn't come to bear until it becomes severe. So there's something, so maybe there is a dose-dependent thing, or maybe it's just because they've been taking it for a while. But as long as they're taking, not all people that take antipsychotic, but if this syndrome comes to pass, they'll have a chronic rhabdo. And not a clinically significant rhabdo, at least in the short term, but a chronic rhabdo. Other things that can help when you have muscle breakdown, you also have cells bursting, so LDH, about 300 or so. Alkaline phosphatase, the metabolic damage happens to the liver, so elevated liver enzymes. Hyperkalemia, obviously they'll have a kidney failure maybe from the rhabdo, they might have an acidosis, so they'll have hyperkalemia from shifting, or they'll have cell lysis. All those three things might cause hyperkalemia. And then the metabolic acidosis, right, from usually the kidney failure. So Also, acute kidney injury, we all know rhabdo. In severe cases will cause AKI. So, and then here's a little just the graph about how it presents in this one study of 79 patients. Clinical investigators were able to recognize mental status and rigidity overwhelmingly more than the fever and autonomic changes related to people that are eventually diagnosed with this illness. So early on, but there might be biases in this study because, you know, it's a subjective bias, and that maybe you know, so many are treated because you see these changes and they're treated early. They diagnose it as neuroleptic syndrome, but you don't have the hyperthermia because it's treated early. So a lot of bias in studies, but there's no doubt that if you recognize these things, it can be clinically useful early in the course. So treatment, first things first, you take away the antipsychotic, whatever it is. Try to recognize it's not just the antipsychotics, it's the serotonergics, it's the lithium, it's the anticholinergics, anything that you think that might be centrally acting, just take it away. Supportive care, like IV fluids, if they're hyperthermic, that might help cool them down. If they have AKI, that will help. If they have rhabdo, you want to use a large amount of hydration. ICU monitoring, so they have to be closely monitored. So these patients have to go to the ICU because it's a progressive thing and you don't know what's going to happen. You don't know if they're going to settle down, and it could snap and they can get hyperthermic. So they have to be in the ICU. Cooling blankets, blood pressure control with vasodilators, because vasodilators will help, like nitroprusside, will help the cooling effect. And centrally acting meds might shut the whole thing down, hopefully, like clonidine. So only if they're hypertensive, but you want to give them either nitroprusside or clonidine, maybe together or individually. That might help your help them cool down. You can give benzodiazepines; those won't hurt. That'll help them settle down. It also has if they're hypertensive, it also has a vasoprotective effect, vasodilation. I think I made up that word right now, vasoprotective. And then dantrolene does work, and that's actually the second line agent for these. So we think about the dantrolene before we think about the bromocriptine, which is the dopamine agonist. So dantrolene is like so effective. So what's going on there is might be related to malignant hyperthermia. Let you chew on that. So dantrolene you could use, and then bromocriptine and amantadine. Those are both pro dopamine agonists. And we know the mechanisms of those. Anybody trying to have a baby? Or no, prolactinoma, right? Never mind. Disregard that last comment. Anybody who's trying to not, anybody has abnormal breast tissue or leaking, was it not even breast tissue, it's leaking from the breast. So bromocriptine, which is used for prolactinomas, is also used for, my point is also for neuroleptic malignant syndrome by the same mechanism. Okay, so any questions about that topic? Yes.
I want to make one comment. Withdrawal from Parkinsonian medication, like carbidopa.
Yes.
So breathization also cause MS. Those are the factors.
Yes, that's very important because then you don't want to keep it away. In the case of carbidopa and levodopa, which are pro-dopamine agonists, if you have a patient that's taken those drugs and has Parkinsonian features, hyperthermia, you diagnose neuroleptic malignant syndrome, you just, in that case, you give it back because that's a special case where the withdrawal is causing the activity and not the drug itself. Because by the same mechanism, you don't have any dopamine activity. And the lack of dopamine activity is what causes these centrally and peripherally acting effects. So it's a good point, and thanks for catching that. So malignant hyperthermia. Oh, so any other questions about NMS? Yeah. Okay, so malignant hyperthermia. I chose it last because it's the rarest, but it also is the most severe. It probably will be it happens in ORs and not necessarily ICUs, but they'll be transferred to ICUs. It's a hypermetabolic crisis with when an MH susceptible person, so it's a genetic predisposition somebody has. It's a very rare mutation, and it doesn't, even if you have the mutation, it doesn't happen all the time, or it might never happen, or it might happen once in a blue moon if you're susceptible. An MH susceptible individual is exposed to a volatile anesthetic like halothane, isoflurane, the gases, or alternatively, succinylcholine. So genetically susceptible. So there's the abnormal, the RI and the DHP receptors in the skeletal muscle. I don't have the entire mechanism. Just the basic understanding is that you have unopposed contraction from increased calcium in the sarcoplasmic reticulum. So you just have prolonged contractions, and that leads to muscle damage, metabolic damage, hyperthermia, and those things. So it's not happening centrally. It's happening at the site, primary, at the muscle. The time frame occurs while they're receiving the anesthetic at some point, but usually in the first hour. Or the anesthetic or the paralytic or the muscle relaxant in the case of the succinylcholine. Diagnosis, just like the other ones, the only, I think, only serotonin syndrome has a verified diagnostic criteria. So this is also from clinical findings, you know, patients 110 degrees and they just started the isoflurane and you think, yeah, duh, that's what it is. But there's no subtle diagnostic criteria to differentiate. So you just use your clinical judgment. So clinical signs. So the most prominent one is found to be hypercapnia. Perhaps this is my conjecture, and patients just trying to cool themselves or panting. It's because they're really hot. So hypercapnia. Tachycardia, rigidity, rhabdo, hyperthermia, and arrhythmia, cardiac arrhythmia, which is a consequence of the hypermetabolic state associated with hyperthermia and just metabolic injury. Lab signs, just like with the severe cases of neuroleptic malignant syndrome, hyperkalemia for the same reasons described earlier with the cell lysis, the kidney failure, and then the metabolic acidosis, rhabdomyolysis, kidney failure, and then liver failure is from the metabolic consequences. So they'll have elevated enzymes, just like, so your labs will look just like NMS. So you can't differentiate it based on that. Your treatment is immediate removal of dantrolene. Oh, immediate. So take away the gases, obviously. Stop the procedure, stop the anesthetics. But at the same time you're doing that, immediate dantrolene, because that's the only thing that's going to work in these severe cases is give them dantrolene. And the reason it works is because we know it just completely decouples the mechanism that causes skeletal muscle contraction. And then they need it for, yeah, so, and the thing is, it's not much toxicity with dantrolene, so you can give it even if you suspect it. And not all ORs actually have that on, they have a hyperthermia protocol, but not all cold carts have it because it's pretty rare, but when it happens, it's like really happens. But that's something people are trying to push, is make every OR have a, like we have epinephrine and yeah, like as if we have epinephrine, have all ORs have dantrolene. And then supportive care, once you've taken away the anesthetic and given the dantrolene, you just keep in the ICU for 48 hours and they'll gradually improve. Okay, so I promised you earlier that we're going to figure out a simple way. I didn't promise you, but I mentioned we're going to find a simple way to differentiate the three syndromes clinically so you can make your decision and you can find out soon and you can treat as soon as possible and have a good explanation as to not embarrass yourself. Oh, I missed it. I'm sorry, guys. I've been losing these chats. Before I move on, I'm gonna go through these chats and whoever has questions, I want to answer to the best of my ability. We still have enough time. So, Saab said you can use Benadryl for NMS as well. Okay. Yeah, as long as it, yeah, you can use Benadryl for it. But not serotonin syndrome because that can prevent the sweating. And then quad fever is very uncommon. Severe hyperpyrexia, more often seen in trauma. Interesting. I'll have to read about that. Thank you. Is the gold standard for diagnosis the halothane capping test in muscle biopsy? Oh, you know what? I read about the hyperthermia and I actually didn't see that. That's really interesting. It's probably one of those confirmatory after the fact things, or it can find people who are susceptible. One of those things. But maybe that's what it is. But I'm not an expert, but those are all good points. Now somebody raised their hand. I guess that's going on. I can't see that. Okay, let's move on. So any questions about malignant hyperthermia that I can actually answer? Because I don't know the answer to the other ones, even though there were such good questions, good comments. Oh, okay, let's move on. All right, so this is how we differentiate it. So serotonin symptoms is a widespread saturation. These are my own words, that's why nothing's referenced. Widespread saturation of the serotonin receptors leading to nonspecific clinical syndrome. You just got everything. When you see a critical care question that says the patient's got mydriasis, sweating, vomiting, has arm pain, limb pain, diarrhea, you just say serotonin syndrome because it's everything, right? Photophobia, they can't turn their head left. So nausea, vomiting, diarrhea, but the thing is, if they have nausea, vomiting, diarrhea, that's very helpful because only serotonin syndrome has those effects, those cholinergic effects, because it's systemic. It goes in the GI tract, it's peripheral. And then the treatment would be supportive care, and that the difference is that the others don't respond to cyproheptadine, but only serotonin syndrome does. So don't make the mistake of getting somebody who they think is on an antipsychotic, getting similar features to serotonin syndrome, cyproheptadine, it's not going to help you. And then it's usually less severe. It has a prolonged course and it's less severe. Like as far as acute clinical course, it kind of gets gradual, and they'll develop the hyperthermia. But when they get the hyperthermia, if you give them benzos and you cool them, it's probably easier to take it back down. Neuroleptic malignant syndrome is a direct dopamine receptor. So one's serotonin increase, the other one's dopamine blocking. The presumed hypothalamus or direct axis is called, so those are important. Those are the theoretical causes of it. But it follows a very more specific temporal clinical pattern, not these scattered and everything all kind of gradually accumulating like serotonin syndrome with the catatonia, rigidity, catatonia, and then the rigidity, with the rigidity like the Parkinson's. And then comes on the hypertension, hypotension, and hyperthermia. It just comes on. Yes, sure.
I'd been on antipsychotics, but was not rigid.
Yeah, that's a good question, Sharon. Thank you. The question is, can you see the rigidity, or do you have to see rigidity as separate, or can they just have a low-grade fever and you don't know why, or something like that? Yeah, absolutely. That's why there's no diagnostic criteria. These are usually trends, but you can have a patient that has fever without the rigidity or the mental status changes to be also. You can have one or any of those. So any of those can occur individually or together or at any time. It's just typically you'll see the coupling. But letting, how many patients do you have that you don't pay attention to, or no, I shouldn't say that, but you don't notice, or suddenly have met like catatonic, or just you think maybe ICU delirium or something, that typically. But usually, if it's caught, those will be caught first. Maybe it's very subtle. But those will be caught first. But any of those features can happen individually or all together or at any phase at all. So I wouldn't be surprised if somebody has a chronic fever if they have like a low-grade malignant syndrome, because we know that CK can stay elevated people on neuroleptics. So I wouldn't see why, by the same logic, they can't have a persistent fever as well. But that's just me making a conjecture. It's my third conjecture of the talk. So it has a higher mortality than serotonin syndrome, and it responds to dantrolene and bromocriptine. Dantrolene first, then bromocriptine. So serotonin syndrome, widespread saturation, everything all at once, not so severe, nausea, vomiting. And then the cryoheptadine. Neuroleptic, no nausea, no vomiting, just the catatonia, rigidity, and hyperthermia. And then dantrolene or bromocriptine. And then malignant hyperthermia, which is the highest mortality, but much more rare, is direct spontaneous action of the skeletal muscle, highest mortality, dantrolene only. So that's the difference. Okay, I got a minute here. So that's my talk. Any questions on any of those things? Thank you for the participation. But I just want to say the interesting thing to look into is the relationship between NMS and malignant hyperthermia, because that might be a serious chronic side effect of people on antipsychotics, and there might be some kind of relationship there where the toxicity to the muscles can cause like muscle wasting or those things, and then be, it's just something to think about, and it's something to look into. Oh, chat, thank you. Yeah, look at the chat. Oh, you're okay. All right, great. Thanks, Masad. I'm glad they caught it, and I'm sure that they're doing okay. Oh, I'm gonna stop this thing.